Hello, and thank you for joining the Donut of Destiny. This is a special industry-sponsored episode. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Thank you for joining us.
GE Healthcare is a proud sponsor of the Donut of Destiny. At GE Healthcare, we see possibilities through innovation. We're dedicated to providing integrated solutions to make hospitals more efficient, clinicians more effective, therapies more precise, and patients healthier. Together, we're creating a world where healthcare has no limits. Make sure to see more today at gehealthcare.com.
Hello, listeners, and welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. On today's special industry-sponsored episode, we continue the Building a Cardiac CT program series. I'm joined by my esteemed guest, Dr. Seth Uretsky. Dr. Uretsky is a cardiologist, cardiac imager, and the director of cardiovascular imaging at Morristown Medical Center in New Jersey, which is actually my old hometown where I'm from. He has extensive experience in multiple modalities, including cardiac CT, as well as MRI and nuclear medicine. Seth, welcome onto the podcast.
Thank you so much, Praveen, for having me.
Excellent. It's great to have another Northeasterner on the podcast, but I want to make sure that all of our listeners know you as well. So let's talk a bit about your history. Where are you from originally? What is your journey through cardiac imaging been thus far? And maybe we can then conclude with your description of your role currently at Morristown Medical Center.
Absolutely. So I was born in Brooklyn, New York, and I grew up there, and I lived in Manhattan for many years. And after doing my cardiology fellowship, I did a year of cardiovascular imaging in Manhattan, and I started my first job. It was a good system, but it wasn't moving along as I liked in terms of developing the cardiovascular imaging. And then I got an offer from Dr. Linda Gillum, who was at Columbia. And I got to know through my research in valvular heart disease, because she's a valvular heart disease guru. She became the chair at Morristown Medical Center, Atlantic Health System. And she said she needed someone to lead the cardiovascular imaging. So in October of 2013, I moved over there and I became the first director of cardiovascular imaging at Morristown Medical Center, Atlantic Health System. And she and I, together with radiology, have built up the program over the span of a decade plus.
Fantastic. So you've got quite a history with Atlantic Health and Morristown Medical Center specifically. To flesh that out a little bit for our listeners, what is the relationship between Atlantic Health and Morristown Medical Center?
So Morristown Medical Center is the sort of crown jewel or the mothership of the Atlantic Health System, which is a 5-hospital system in, I don't know that it's technically central Jersey, but it's sort of, I guess it is sort of the middle of Jersey, of the state of New Jersey. And our hospitals are spread over a wide geographic area, and we serve a very, very wide variety and array of different types of patients.
Seth, without diverting too far away from the main topic at hand, you brought up the concept of central New Jersey, which can occasionally be pretty controversial inside New Jersey.
Yes, that's right.
Yeah, as being a prior central New Jersey resident myself, I know the challenges that come with that particular geography, but appreciate that in terms of helping our listeners understand where geographically we are. Let's now talk a little bit about the history and growth of the cardiac CT program specifically at the varying sites, including the flagship, as you had mentioned, Morristown Medical Center. Can you walk us through what you walked into and where it's at right now?
Absolutely. So when I got there, it was a very, very, very small program. There was a 64-slice CT scanner at Morristown Medical Center. And they were doing 3 cardiac coronary CTs for 3 days a week. And the other 2 days a week, they were doing 2 TAVRs. And that's kind of what I walked into. The nurses would beta block the patient in a small room with a mobile where you can do vitals, and that's how they did it. So when I got there, there was a reading panel that currently existed. And what I started to do is let the readers keep on doing what they're doing. And I slowly started making myself available for additional studies, building up the program, and educating people about what cardiac CT was. Now, you have to remember back in those days, in 2013, there was no class 1 indication for assessing chest pain with cardiac CT, with coronary CT. So it took quite a bit of education. But what I find in cardiac imaging in general is if you make yourself available to the cardiologists and the internists or whomever wants your services, and you inform them, and you're willing to do studies, even though it may not be convenient for you, as long as you focus on that patient and you help them take care of their patients, they will generally come back to you. And we did that slowly but surely. And I focused on quality, quality, quality. And that's always been my focus, whether it's cardiac MR, it's nuclear cardiology, or cardiac CT. I really focus on quality. I make myself available to the text, or all of our imagers are available to the text. They know they can call us at the drop of a hat. If they have an issue, we'd rather them call us than have a non-diagnostic exam. And slowly but surely, we started building it up. There was also a small program at that time at Overlook Hospital, which is the second largest hospital in our system. And we started building it up as well. As the programs got busier and busier, Atlantic Health started putting more money into the system. And we were eventually able to upgrade to higher scanners, more of them, put them at all the different hospitals and outpatient sites. And it kept on growing and growing. And I don't have to tell you that cardiac CT, of course, took off the last couple of years with the change in guidelines, but also it being such a good way of assessing patients quickly. You can get them in and out of the ER, in and out of your office. So it's become a very useful tool for us to assess patients.
Seth, there's a tremendous amount to unpackage there in terms of how you've grown it to obviously a humongous, impactful system across all of cardiovascular medicine and we'll say central New Jersey. With that in mind, though, I want to start by talking about one of the first things you mentioned in that response about quality and your discussions with your technologists and nurses. Could you talk to us about what communication channels you use to keep that conversation, that dialogue going with your technologists and nurses and ensure that your exam quality stays optimal?
Yeah, so the way we do it is at each site we have radiology nurses or cardiology nurses who do an intake on the patient, and then initially they would call us and give us a little bit of, okay, this is what the patient's here, or I don't know why the patient's here. Do you mind looking at the chart? I'm confused. It's not clear. Sometimes charts aren't clear. And we want it because we want to make sure we get the protocol right. Is it a left atrial appendage protocol? Is it a post-TAVR evaluation? Is it just a coronary? What is it, a congenital case? What's going on here? How do we want to protocol this? Now we have Epic, so we use secure chat. And what the nurses do is they secure chat us. We took this patient in. We've given them this much blocker. This is the heart rate. What would you like to do? So that's the first line of communication, of course, is with the nurses. And we try to make sure that, between myself, the nurses, and the technologists looking at the patient, we don't really miss anything because sometimes things get lost in translation. Not every single patient that we have is within our Atlantic Health system. Because we do a lot of studies, we get many patients from outside our system. So we rely on notes, which are scanned into the system. So we have to make sure we're doing the right thing. Then, after the beta blocker, and we tell the nurses when we have nitro, they go to the technologist. And the technologists have all our phone numbers, and they know that whether they have questions about the protocol, whether having difficulty with the heart rate, whether they acquired images and they're not clear whether these are satisfactory or not, they call us. And they know we will answer them at the drop of a hat. So we like to take the guesswork out of the system. We don't want the tech to say, oh, I don't want to bother the doctor. No, bother us. I'd rather answer you and do the right thing and have a high quality image than say, I don't want to be bothered, and then I just get what I get. I don't think that's fair to the patient. I think the patient's coming, they're getting, although a small dose of radiation these days, they're getting contrast. It's our obligation to make sure they have the best quality images.
Excellent. So you've decoupled your location from the scanner, but maintained pretty much constant contact with your technologists and nurses, who are the boots on the ground, obtaining the images for these patients. Just to put a final pin in that idea, do you all have the ability to review those images either in real time or shortly thereafter to talk about any modifications that are needed?
In fact, we do review them in real time. We're generally one of us or two of us are right in front of our server. We have a server system, and we're able to review the images. Interesting that you said decoupling. For cardiac MRI, we've not decoupled ourselves. We are at the scanner. There, of course, are fewer sites. But for cardiac CT, given the less degree of uncertainty on the tech side, we have, by force, have had to decouple ourselves from the scanners, but we have coupled ourselves, but we are still coupled to them with communication. And we do. We review. I've gotten a call today from a tech saying, "Listen, I did the CT. The patient's heart. There was a lot of PVCs. They were jumping around. Do you mind looking at the images before I take the patient off the table?" And I do it right then and there. And then the patient goes on their way. So we are at their beck and call, so to speak. And I think it helps the quality of our images.
Excellent. So, Seth, you had mentioned cardiac MRI. I want to bring some ideas about multimodality imaging now. You have plenty of education and experience and currently clinically practice in a multitude of cardiac imaging modalities. Could you talk about your approach to balancing the utilization of each of the different service lines, obviously cardiac CT included, to effectively triage specific patient presentations or to ensure that there's adequate allocation of resources to all of these from your position as the director of the imaging division?
Yes, that's a great question. And often, sometimes these modalities will compete with each other. What I try to do is I try to understand what the referring physician wants, what the patient needs, what their issue. And then I try to pick a test that will answer the question as opposed to doing multiple tests. And usually that's very, very helpful. Sometimes there are just instances where it could be one or the other, and it's preference of what we have at that time. What's the easiest way to get the patient in and out? But in general, what I try to do is I try to take, let's say, for instance, with chest pain, I feel that one good dividing line, and maybe not everyone agrees with me, is if you have no known coronary disease, I think CT is a great test for you, right? Because we'll pick up subclinical atherosclerosis, and hopefully that will lead to a change in management. If you have some mild plaque, and then the data says that helps patients do better in the long term. As opposed to patients who have known coronary disease, then you might consider, if they're obese, doing a PET scan, if they're normal weight and they want to exercise, doing a SPECT scan. So we try to put the patient where we think is best. We don't worry so much about if each modality will have enough patients, because we have so many patients and we're so busy. I think that either way we'll do enough of all modalities. It's more important to do the right thing by the patient.
Excellent. Let's hone in now on the non-human side of cardiac CT, because you had mentioned clearly the enthusiasm and well-oiled machine on the human side for ensuring adequate image quality. What sort of equipment are you working with across your sites? And is this recently installed or pre-existing for a long time?
So we are we have really a bunch of GE Apex scanners. These are not recently installed. We've been working with them for a number of years. We started with the GE Revolution, and over the years we have those scanners were upgraded to the Apex, and we have a number of Apex scanners across our system. And we have found that we almost never have a problem with quality images when we use those scanners. We have diagnostic studies. Of course, calcium is still a problem, and blooming artifact is still a problem. But I really enjoy the one heartbeat acquisition. I think that takes a lot of the guesswork away. You don't have to worry about trying to acquire a scan over several heartbeats. Maybe there'll be a PVC, maybe there won't be a PVC. I find the one heartbeat acquisition and the temporal resolution is very good on the GE Apex. I like the way the images feel, the way they look. They do a great job of separating out calcified plaque from non-calcified plaque and highlighting the coronary artery. So we have found these scanners to be very good, but also very versatile. They're very good with left atrial appendage studies. They're very good with congenital heart disease. Depending on what you're looking at, you can do different things with it. So we have a bunch of these in our system. We've been using them for many years, and we're very happy with them.
Excellent. And for our listeners out there that may not be familiar with the GE Apex platform, we're talking about wide detector coverage scanners, 8 to 16 centimeters of coverage that allow, Seth, as you're mentioning, whole heartbeat acquisition. Did this allow for any changes in your, say, your medication regimens for patients, or was there any additional post-processing bells and whistles that came alongside of the new scanners that changed your workflow from the pre-existing workflow?
So that's a great question. So my attitude has been that even though the scanner can handle much higher heart rates and give you excellent images, I still like to beta block the patients first. And I do it for two main reasons. One is lower the heart rate, less radiation. Now, I understand it's not like we were doing 15 years ago. It's not an incredible amount of lower radiation, but I still feel the Alara principle is important. So if your heart rate's 55 and I gave you a dose of beta blocker, I don't need to scan you as much as if it's 70. So I think that's important. Number two, with the Apex scanner, it's a great scanner. If your heart rate's in the 70s or 80s, you're 97% chance of a pristine diagnostic study. But if I give you a little beta blocker and I get you down to 60, it's 99.9%. And again, if I am exposing a patient to radiation and I'm giving them contrast, I'd rather have the 99%. So we've decided to continue beta blocking the patient. With that said, if we beta block the patient and the heart rate's in the 70s, I don't really worry about it too much because the Apex scanner does a great job even at those heart rates. In addition, there's something called snapshot freeze, which allows us it's an AI algorithm that GE has. What it does is it looks at all the recons you've done. It chooses the 3 best. And out of those, it has an AI algorithm that removes motion. To be honest, I was quite skeptical in the beginning when I started using it because I like to read off raw images. That's how I was taught. I don't like anything manipulating my images. I feel the more I manipulate them, the further I get away from what they would look like, let's say, in the cath lab. What do they look like in real life? But I actually have found the snapshot freeze to be a wonderful tool. And it's really it's saved us a couple of times with difficult patients with lots of PVCs. It does a really good job. So heart rate 70s, 80s, 90s, I say, let's give it a shot. And more often than not, 99.9 out of 10 times, we get beautiful images.
Awesome. Seth, honestly, with any vendor, these modern day scanners capable of all of these advanced cardiac CQ acquisitions and post-processing techniques, they're expensive. And you had mentioned that earlier in your response that a lot of the budgetary stakeholders noticed the impact of the growing cardiac CT program that you were building before these scanners, the Apex scanners, were installed. Could you talk to us about how you navigated that budget allocation process for these obviously very expensive pieces of equipment, even beyond cardiac CT, if you'd like, and perhaps what factors or arguments were most persuasive in securing this funding?
Absolutely. So one thing we have at Atlantic Health is we have an excellent relationship between cardiology and radiology. We really work in tandem. And so what do I mean by that? Well, not only do we have cordial and we're friendly, they help them, they help us, but we strategize together. Where do we want to put scanners? Where's the best place to put scanners? So I'm consistently meeting with radiology administration. Okay, which of these scanners would be a good cardiac site? Now, when you go to administration and you ask for money for these expensive scanners, it's much easier when you have 2 large departments coming and asking them, hey guys, we want this scanner. This is what we're going to do. This is the business plan. Than if you go alone. And we found having these strategy sessions, agreeing on what we want to do, and then going to administration has helped us a lot. It has also helped that cardiac CT at the same time is growing. So the hospital is making money off the program. But because it's shared equipment, I don't have to worry about filling up cardiac CT from the morning to night. If we have an open spot, beautiful. We'll put a radiology study in there. So there's never any downtime. There's always a strategy of what we're doing. And when we go to administration, it's always our 2 departments going together, hand in hand.
Very interesting, Seth. So this implies then that all the scanners that you're performing your cardiac CTs on are quote unquote shared scanners performing cardiac and non-cardiac duties wherever they may be. Is that correct?
That's absolutely correct. And I prefer it that way because, especially in the beginning, I didn't want to have the pressure of going to administration and saying, get me a scanner. Okay, you got 20 cardiac CTs to fill the day? Well, maybe I do, maybe I don't. But if I only have 5, guess what? You could do a lot of radiology studies. And that always made sure that we were making money on the scanners, and administration was always happy.
Given the cordial relationship you have across these two departments, how does this translate into providing the interpretations for the exams? Is it primarily from cardiologists, from radiologists, a mixture of the two?
So in our system, cardiac imaging lives in cardiology. But what we do for each set of studies, so let's say for a coronary CT, radiology does a lung overread. So we read the study, we drop the bill, but in the background, they get a bit of the RVUs as well. So everyone's happy. For a TAVR, since we order it as a chest, abdomen, pelvis, they read the study, they drop the bill, and we do a coronary overread. So we work together. We split the RVUs when we make money together. So everyone's happy.
Wow, that's fascinating. I've heard a variety of different methods by which cardiologists and radiologists can collaborate, not just on the interpretation, but on the billing side too. And without obviously divulging too much of the financial details, it sounds like you're splitting RVUs with the primary being either cardiology or radiology. Is my understanding correct there?
That's correct. And the radiologists love it because we bring all the studies in, right? Because they're cardiac studies and they get a very easy chest overread to read, let's say, so to speak. We do the same thing for sarcoid studies. And what I try to do is who's ever doing the most work will drop the bill, and the other department will get the RVU in the background. So obviously for most cardiac studies, we're dropping the bill. We're getting the bulk of the RVUs, but they're getting something in the background. So it's really a team effort. Don't forget also, if they have a patient who, let's say in the MRI suite, right? They have a patient with a device they're not comfortable with. They'll come to me and say, "Hey, will you handle this device with us?" Of course they will. I'll handle the device with you. The patient needs a head, MRI. What do I know about reading a head MRI? But I'm happy to help, with the EP part of all of that. So we have a very cordial relationship, and it's done us very, very well.
Yeah, it's a testament there, right? The cross collaboration is mutually beneficial for both departments. Awesome. I want to shift gears a little bit and start talking about advanced post processing software that you may be using. Do y'all leverage any specific tools such as, say, FFRCT or plaque analysis in your current cardiac CT workflow?
Yes. So we have both FFRCT and Clearly for plaque analysis available. But now Clearly is going to start doing their own FFR, and we're signing a new agreement with them. And HeartFlow is also going to do plaque analysis. So we'll have both these companies doing both these processes. And the question is, how are we going to allocate which studies to which, and which ones will we like better? And I do not have the answer for that because we're just getting in that space. What's driving this is obviously for FFRCT, you just need it. For plaque analysis, well, obviously the data is growing now and they're doing the studies now. I'm going to be honest with you, it's being driven by referrers. A lot of our referrers want to know, well, okay, it's great that there's a stenosis, but how much plaque volume am I dealing with? What's happening? So a lot of that is driven by the people asking for the information.
Wow, Seth, I've had a slightly different experience on that side. I've had to try to educate some of my referents on some of what the benefits of plaque analysis would be, but it sounds like the opposite is true where you're at. Cool. Interesting.
For some people, obviously, listen, you know this, there are referrers who will never send you a cardiac CT study, or some of them will never send you a cardiac MRI study, and then some who use it a lot. So I can never figure out who uses what, why. It may sometimes have to do with how they were trained or the population of patients they're treating and what tools they prefer. But yes, a lot of the plaque analysis I am finding is driven by people asking for it.
Obviously, these referents are going to be other members of your cath lab team, of your structural cardiology team, your electrophysiology team. Out of curiosity, do y'all either track metrics from or have formal discussions with the members of other non-imaging portions of the cardiology department to see what benefit cardiac CT has been having on their workflows?
Yes, I would say that most of our work is driven by the cardiologists in their office. In other words, the guys seeing the patients. It's interesting. Some of them are naturally guys in the cath lab, no doubt about it. But they're saying they see 20 patients a day on their panel, and they have a chest pain patient, and they want to get a cardiac CT. So it's driven a lot from them. It's a mix. I find that the EP guys drive a lot more left atrial appendage, and the valve guys sort of drive what they're doing, what the kind of patients they see. But a lot of our work comes from the bread and butter cardiologists.
Could you talk then about where you envision future growth across the health network? Is it coming from those general cardiologists, or do you see or envision growth in other spaces?
So I do envision continued growth in the chest pain area, just plain old coronary CT. We're seeing large volume growth, sometimes almost 20% a month. Obviously, some months are up and down as the year goes. But I am seeing a significant growth in left atrial appendage assessment prior to Watchman, and in many cases, prior to AFib ablations for some electrophysiologists. They say, why should I do a TE, which is not really a non-invasive test. We call it a non-invasive test. But, if you want to swallow that tube, it's not so non-invasive. You can go in the tube, or the tube can go into you. That's what I tell them. So I think we're going to see growth in that. I think also as the adult congenital population grows, I think CT is becoming a very important tool in that. For the reason that a lot of times the congenital heart patients' history is a little murky, and you can do a cardiac MRI and sort of be Sherlock Holmes there and try to figure out what's going on. But sometimes it's easier just to put them in the scanner and get a nice CT, and you know where everything is, especially when LLM has devices which cause significant artifact on MRI. So I think that's going to grow as well. And the other area we're seeing growing is post-TAVR evaluation and post-prosthetic valve evaluation, where I think a lot of transesophageal echo people are realizing there's a lot of shadowing around, and that in CT we do a really good job of really looking at the function of valve, whether there's any thrombus or any calcifications around the valve. So that is also growing quite quickly.
Awesome. I mean, we in the cardiac imaging community, beyond just CT, are feeling the growth in every modality every single day. And I want to ask you what sort of challenges you envision with the growth of your program and how you may hope to tackle those challenges.
I think the challenge is getting enough scanners in enough places and keeping your eye on the ball so that every scan, you're giving it your all to do high quality study. The other thing we do is we educate cardiac imagers. So we have an imaging fellowship, and we try to make sure that there'll be enough cardiac imagers out there, both in the radiology and cardiology realm. That's going to be an important challenge for us as these advanced imaging modalities grow. Now, I don't know much of what goes on in radiology, but within cardiology fellowship, the general cardiology fellowships, I would say that cardiac CT, cardiac MR, and even PET scanning, many sites don't have them, so they can't educate their fellows. But even that, I don't know that these imaging modalities are integrated into general fellowship. So we suggest that people undergo a 4th year of training, and we treat it that way. We treat it like as if you want to be an interventional cardiologist or you want to be electrophysiologist for heart failure. Our feeling is you should spend a year doing cardiac CT, cardiac MR, and PET scanning and really become a specialist in it, as well as structural echo, because a lot of general cardiologists are not trained in that either. So I think one of the important things is to churn out very well-trained radiologists and cardiologists who can do this.
Seth, I think this has been a fascinating cross-section into not just the program at Morristown Medical, but really the entire system at Atlantic and what your role has been in it. Super appreciative of your time. Could you provide us with any final thoughts about your program specifically or cardiac CT in general before we close?
I think this is an exciting time for cardiac CT and cardiovascular imaging in general. I would like more fellows and more radiologists to get involved in it. I think it's a great career. It's an exciting career. I think that the companies have done a great job, both in the cardiac MR, the cardiac CT, and the PET space to really improve the scanners, really improve the technology, the technology we use to evaluate the studies as well and interpret the studies. And I really am amazed over the last 10 years what's happened both in industry and in terms of the explosiveness and the training and the number of people want to go training. So I think it's a very exciting time. I think there's also people are interested in research. There's a lot of research to be done to figure out, as you mentioned earlier in the podcast, which imaging modality might be best for which patient. So it's a very exciting field. It's a very exciting time. And I think the future is very, very bright for cardiovascular imaging.
Seth, super insightful thoughts. Really, really appreciate your time on the podcast and your expertise that you bring to all of cardiac imaging beyond just cardiac CTs. Really, really, thank you so much.
Well, thank you for having me.
Of course. Thanks again, Seth. To our listeners, as always, thank you for tuning in. If you like what you hear from us on the podcast, please rate, review, and subscribe. That helps others out there find content like this. Once again, this is the Donut of Destiny. Cheers.